Co-creating the future isn't just this year's slogan. It's exactly what happens when the public sector and the private sector learn from one another. Today, we'll show you how this collaborative mindset is helping a budget-driven hospital environment turn into one that can think about being reimbursed through diagnosis-related groups, or DRGs. So I'm going to start by saying the public sector is very different to the private sector. The public sector is funded through budget allocations, and because of this, it's organized very differently to the private sector. This extends to the organization of information and data. As you can imagine, budget silos create data silos. Costs, activity, and outcomes are all stored in very different places. If the public sector is funded through budgets, then why are DRGs important? Well, the NHI bill signed by the president talks about hospitals being reimbursed either through global budget or diagnosis-related groups, DRGs. Within a purchaser-provider split, though, the fund needs to actively and strategically purchase care. And so we think DRG-based reimbursement is the more likely or logical choice. However, even if a global budgetary approach is maintained, basing this on case mix using DRGs is a far more accurate way of allocating resources than the current methods used. Before we go any further, for those of you who might not know, let's take a step back to discuss what DRGs are exactly. Every patient is unique. We all agree on this. But we need some way in which to group patients into similar categories so that we can understand in-hospital costs. DRGs use diagnosis and procedure codes to create clinically intuitive patient groups. Adding cost of care data to this means that we can create resource homogeneous groups. What this means is that all admissions that fall within the same DRG are expected to be clinically similar, as well as expected to be associated with the same resource use. As the name suggests, DRGs are essentially a grouping algorithm, and it's important to note that this applies to inpatients only. Other groupers exist, which consider out-of-hospital experience, like our episode grouper or our episode patient grouper, but DRGs deal with inpatients only. Funders and providers are often at odds with one another because of looking at different sides of patient data. Doctors think clinically, while funders think in terms of rands. DRGs create a common language between them, allowing both sides to talk about the same case. This reduces the amount of tension between the two parties. This common language has proven especially useful in the private sector, where DRGs are already used extensively, since it allows the quantification of the mix and severity of hospital cases. So what do we mean by case mix? Perhaps this is an oversimplification. Tough crowd, eh? But imagine you receive a case of wine and you open the box expecting 12 identical bottles, but instead you find a mix. Some light, some heavy, and maybe one even with a cork stuck that's undrinkable. In healthcare, every patient comes with their own level of complexity. Some are straightforward and easy to manage, while others are more complex and resource intensive. So when we look at hospital data or compare costs or outcomes, we have to consider the mix of cases or patient profiles that present to each hospital. An understanding of case mix and the ability to account for the variation in case mix is a prerequisite to any meaningful cost or quality benchmarking assessments. It's crucial that we're comparing apples with apples, or in this case, Merlots with Merlots. These benchmarking assessments are needed to create an efficient healthcare system, allowing funders and providers to have conversations about cost efficiency, length of stay efficiency, and even facilitates level of care analyses. DRGs also underpin a variety of alternative reimbursement models. The differences in the models listed here lies in what's included in the payment and how broadly the episode of care is defined. While the NHI bill is silent on this just gives an idea of the range of possibilities, and it's only natural to assume that what's included and excluded will evolve over time. Insight has been involved in DRG work for over 20 years and has contributed to the public sector work through the NDO DRG Technical Task Team in 2013, as well as provided input to the development of a DRG roadmap for the national and provincial health departments. Given how crucial clinical coding is to DRGs, the roadmap starts with the standardization of clinical coding. This doesn't need to precede the understanding of cost of care. So in the Western Cape Department of Health, the cost of care workstream has been running in parallel to the clinical coding workstream. The clinical coding workstream is focusing on the comprehensiveness and accuracy of diagnosis and procedure coding, which is only achievable through clinical coding audits. The rest of this presentation will focus on the costing side of things. Ideally, we want to know what the actual resources used for each and every admission are, but this is not practical given the way the information is stored and the costs are incurred within the public sector. It's much easier to go from fee-for-service to DRGs than from global budgets to DRGs. So we needed to develop an approach that would give us the best estimates for the cost per admission. We worked closely with the Western Cape Department of Health to develop a framework for how to classify, group, and assign costs to each component of service delivery. What I mean by this is for public hospitals to understand what it costs to provide in-hospital services, it's important to understand the cost components such as staff, equipment, laundry, catering, etc., and how these costs are allocated to different cost centers. Once we have these cost components, we then needed to understand how to combine these into a day in a general ward or ICU or time in theatre for that matter. These became the building blocks for the individual cost per admission. I'll now hand over to Suzanne, who will take you through the Western Cape's experience going through this costing process.
Thanks, Poonam. I am so excited to share our journey in terms of developing DRG costing in the public sector in this collaborative space with Insights. So to understand what we needed to do, we first reflected on what is the landscape that we operate in. Now, I know we're all familiar with this, but just as a brief recap, it starts with, in each department, there's a predetermined objective, such as the equal provision of healthcare for every service. And beyond how do we do this is a question of how will it be funded. So then we'll go to the budget speech where the finance minister will share our economic outlook or perhaps how we might improve our fiscal health. And in the same speech, the departments are allocated funding. It's a bit more complex than that, but that's just the high level. Sorry, lost my train of thought there. Okay. So there are other sources of funding, such as donor funding and potential revenue generation, but this is to a much lesser extent than the voted funds we receive in order to serve the population. Another aspect of how we look is how that financial data is contained, and more importantly, can we connect it to the patient data in order to determine a healthcare cost? Well, in our space, in the provincial setup, finance data and patient data is currently housed independently. And this was the first challenge we had to overcome of how we might marry this information. So then we started reflecting on our data systems and what is the information it might contain. There are many various dedicated information management systems, and it should be known that in each province they have their own equivalents. This is the overview to the Western Cape. So our primary feeder systems include a medicine management system, lab and blood services interface, procurement system, patient statistics system, and then our salary and personnel administration system. Central to all of these is how that line item expenditure is allocated to a cost center, where the cost center is the origin of the expense. And this formed the basis of how we might merge finance and patient data going forward. At the next level, we then looked at how does the data flow and how can we organize this? Our ACE card in this activity was that in our team, we had specialized nurses in a finance setting. So with their deep understanding of the types of facilities in the public sector, the specialized services that we render, and their understanding of cost accounts, it was instrumental in how we scrubbed and mapped the various data elements. So at a high level, the data was then organized into direct patient care costs, which spoke to all clinical related expenditure. And then we have indirect patient care costs, such as our overheads, admin, and management fees. In our space, we also linked corporate support services and hospital facilities management fees, which is programs outside of the hospital expenditure, but relate proportionally to that hospital. On the other side of the data was how that resource is utilized. And this was informed by the various patient counts and the available operating minute data. Right, so now we're armed with a whole lot of information, and we are ready to map every cost to every patient encounter and hopefully finish by the year 2036, give or take. When thankfully Insight comes on board and they introduce us to this analogy of Lego block building. Effectively, in this house of healthcare, we need to decide which cost blocks we need and which blocks fit where, and rather build incrementally. But as Barry will remind us, you graduate to Lego blocks. You start with Duplo blocks, which are much larger and easier to connect. So we were on a mission to find our easy connections. When we thought about the blocks that we needed, we reflected on our patient's journey, where initially they're received in an administrative setting, their profile is registered and their needs assessed, and perhaps they're admitted. Right, all bed-related costs, let's capture this under a block called ward. Very creative naming, but remember Duplo blocks. So if there's any surgical interventions, again, very creative, theatre block, that sounds right. Rehabilitative encounters by an allied healthcare practitioner, let's call that auxiliary block. In our space, we then also created a separate block for nuclear medicine because it is a highly specialized discipline at our central hospitals, and because the costs were well defined in the data, it was easy to separate out. All other remaining costs were then indirect patient care costs, which we assigned to a block called hospital. So our path to Lego block building meant continuous refinement and reflection of the costs at a greater level of detail. And this was made possible through frequent engagement with Insight, where we met regularly to discuss the progress we had made or the challenges that had arisen. And through their immense experience, they were able to guide us through those unknowns or data limitations, such as assets used well beyond their lifespan, which is common in the public sector, or perhaps how we might navigate costs between ward grades when this is not well defined in the data. Through this iterative process, we were then able to map all of the data to the blocks we had developed. And then there were challenges, as any adventure would have it. And the first being, as Poonam's referenced right in the beginning, is that the public sector looks different. There are a few examples to this, but one just to illustrate is where a patient might be admitted to a level 1 hospital, which is representative of our smaller, perhaps more rural hospitals, and then requires a service at a level 2 or 3 hospital. The patient is transferred to the next hospital, service is rendered, and transferred back to the start hospital. In our patient data, this is considered as one admission. But in our finance data, these costs are dispersed between the facilities. Another challenge we experience is that path to Lego block building was not always straightforward. We had to consult multiple system sources in order to bring together those various data views. We also realized that dependency on the cost center model, we had identified that it varied between institutions, where some institutions who were responsible to create and then populate the information had a greater reliance on the cost center model and therefore captured at a greater level of detail. Another challenge was then a limitation to certain system elements, such as the inconsistent capturing of theatre time on a system. And this was perhaps due to the fact that it was not historically mandated, or perhaps just due to lack of capacity. So what have we achieved? Well, I'm pleased to report it is not 2036. And we have mapped 3 years of financial data for our 3 biggest hospitals, a level 2 regional hospital and a level 1 district hospital. We have done the most with the data we have so that we can lock in and start reconciling back to the total expenditure. So what does this mean? Well, we can produce a per unit cost, such as per ward day, per grade, or per operating minute. And this also allows us to start comparing those differences we see between our facilities and might give insight into the source of those variations, such as different procurement processes. And although this is not the end product for DRG costing, this work can also inform the development of other alternate reimbursement models in the public sector. The lessons we've learned is that we have all the right ingredients, but we will require further upscaling, such as bringing together all those various system views in a more useful manner for costing, as well as a greater buy-in by our clinicians and our information management areas for the now necessary data elements. There are many great initiatives in place and well underway within the department, such as our primary health data center being at the fore of building those connections between the systems already, or our information management and technology directorates bringing about intuitive system enhancements, such as the onboarding of a healthcare data dictionary for more clinician-friendly language to drive diagnosis coding. Through these co-creative strategies within the departments and collaborative private partnerships such as Insight, we will achieve the objective of DRD costing in the public sector. I'll hand back to Poonam now to explain what we need to do next.
Thanks, Suzanne. The next step is to get alignment between the clinical coding work stream so that we can move on to the next phase, which is to match the clinical data with the cost data. We need to be able to tell the difference between the cost of an appendectomy versus the cost of a heart bypass. Matching the utilization of each of the building blocks of cost with the unit costs and the clinical data for each specific admission will give us a robust cost per case. Once we merge these data sets and a grouping algorithm is chosen, we can then build up a cost per DRG. The simple example here shows how diagnosis and procedure codes allow for the mapping of this particular admission to the appendectomy DRG. We then use the utilization components and multiply them by the unit cost of the building blocks to get the total cost of this admission. A pneumonia case or a C-section delivery will tell a very different cost story. Once this is done for all admissions, we'll be in a position to determine the cost weights per DRG, which will then enable case mix adjustment analyses and make DRG-based reimbursement possible. Additionally, DRGs will need to be incorporated into the billing and information systems for this to be effective. It's likely that DRGs will run as a shadow process alongside budgets so that hospitals can see and compare their DRG-based revenue to their current budgets. When budgets meet DRGs, managers will finally see what it costs to deliver in-hospital services, and clinicians can then see why efficient care matters. The implementation will require regular monitoring and review with systems checks and clinical audits in order to monitor how the system responds to DRG implementation. The effects of DRG-based reimbursement needs careful reevaluation at regular intervals, ideally in close collaboration with all actors concerned. Critical feedback will then be passed back to step 1 or elsewhere in the process to address any readjustment of cost weights necessary. In this way, the NHI fund is then set up for a fair and efficient payment model that directs resources to where they're actually consumed. We've shared this work to provide transparency on the costing process, and we believe there's a lot of opportunity to build on what's been started. We're willing and eager to share the framework and the learnings with the other provinces as well. This is how we co-create the future of funding South African healthcare. Thank you.